AI teaching course, Multimodality Rigid Emergency Care. I have a great pleasure to speak with Dr. Susanna Price from London, UK. Welcome, Doctor, to Belgrade, and thank you for your time to answer our questions. First of all, I ask you, can you explain us what is the goal-oriented echocardiography and in what way it is different from diagnostic comprehensive echocardiography?
Okay, that's a really good question, and it's very topical, I think. So we have different types of focused scanning. So you have focused cardiac ultrasound and the targeted kind of echocardiogram that you might do in the critical care setting. And the key differences between the focused cardiac ultrasound and targeted echo is that targeted echo potentially uses the full range of techniques that you would use in an outpatient setting, but specifically trying to drill down as to what the problem with the patient is on the intensive care unit. And that's very different from the outpatient setting, where you generally will either be doing a diagnostic test to say what is wrong with the patient, or trying to risk stratify them according to what the existing guidelines say. So we're stepping outside generally of what the guidelines can help us with and using the full range of echocardiography to help us inform the intensivists as to how to manage the patients.
Okay, thank you. How can we guide our diagnosis and therapy with echocardiography in patients with acute heart failure?
Okay, so acute heart failure, again, a very hot topic, and what the ESC guidelines urge us to do is to make the diagnosis fast and to treat the patient fast. And that involves two things, particularly when the patient's shocked, is to get your echocardiogram done very early on, exclude potentially treatable causes, so is there acute valve disease, or is there a new regional wall motion abnormality that suggests the patient should go to the cath lab, for example, very early on. And if you just have ventricular dysfunction with no reversible underlying cause, then you can use your echocardiography to guide you in choosing the best inotropic therapy, or even, if you need to, your mechanical circulatory support.
Okay, you mentioned somewhere before the role of echocardiography in intensive care units for hemodynamic monitoring of the patient. Can you be precise how we can monitor our patient in ICU?
Sure, so we use our echocardiography as an adjunct to our standard clinical monitoring. So you can, for example, use your echo to estimate what the venous pressure is, the central venous pressure, but in the ICU you'll have that measured directly. What we use it for is to look at changes in stroke volume and cardiac output in response to therapies, and also potentially changes in your transmitral filling that might suggest that your left atrial pressure is particularly high or particularly low. So we use it for that, but also we would look at it in terms of pulmonary vascular resistance, pulmonary artery systolic pressures, and use the numbers that we have from the echo integrated into the whole echocardiogram finding to inform whether the interventions we have done have been successful or not for the patient.
Okay. What advice would you give to someone looking to get the most from this teaching course?
Okay, so if you can, in this teaching course, I think what has been really striking is the quality of the presentations and also the availability of the faculty who are really experienced for questioning and for discussions. So I would say it's a good teaching course to come, bring some cases and discuss them with these very experienced faculty.
The last question, we can all agree that in order to be a good physician, we need to love our job.
Yeah.
Did you always want to be a cardiologist?
No, I didn't. I didn't even want to be a doctor. It was really a bit of an error. Yeah, I actually wanted to be a linguist and an artist, and my family are all musicians, but I ended up doing medicine because I thought it would be interesting, and I wasn't wrong. And then more than anything else, acute cardiology is a thing for me.
Yes, I agree. Thank you very much for your time.
Thank you very much.